Hello, my name is Eric Lee, and I am honored to serve as president for the Pacific Spine and Pain Society. I would like to thank you all for attending our first annual meeting virtually, wherever you are throughout the country, and more specifically, the Western United States, the region in which we serve. Our goal here at PSPS is simple. We provide physician support and patient service in order to maintain and maximize the benefits of the therapies we offer to patients to help treat a wide variety of conditions. One of the key tenets to enabling us to do this is education, which is why we believe so strongly in offering high quality, significant content. And we listen to our members to hear what they're interested in, whether that's technology advancements, proper technique, or social injustices that are related to medicine that we can help improve upon. We're honored today to have a very distinguished faculty that will be presenting to you on a wide variety of topics. I'd like to thank our sponsors for the opportunity to support us and allow this presentation to take place today. I'd like to thank our board of directors who works tirelessly behind the scenes for all the content you're going to see today and all the efforts we do for you throughout the year. And I'd last like to thank Dr. Ramo Naidu, the annual meeting co-chair, who did an amazing job putting this all together in the current climate we're facing today. So with that, without further ado, I'd like to turn it over so we can begin some excellent sessions. And thank you again for joining us today.
Welcome to this lecture on the changing history of neuromodulation. For those of you who don't know, I am Robert Levy. I am the current president of the International Neuromodulation Society and also the editor-in-chief of the journal Neuromodulation Technology at the Neural Interface. Before I go further, let me identify my disclosures. These are over the past 2 years, and I should note that this slide was much larger and is diminishing to 0 as the new conflict of interest requirements of the International Neuromodulation Society require full lack of conflicts of interest of both the president and the editor-in-chief of the journal. Before I get into the talk in particular, I'd certainly like to highlight that these are certainly auspicious times. We have not only the impact of the COVID-19 pandemic. Today, as I'm recording this, is the 19th anniversary of the 9/11 disaster. And on top of that, particularly on the West Coast, there is a horrific spate of wildfires that risk many of us who are involved in the practice of neuromodulation throughout the West Coast. So with this being superimposed upon such a conference, I really want to hold my hat out to all of those who have organized this conference and support this conference for their tremendous forbearance, their dedication to education in neuromodulation and pain medicine during these very trying times. So I salute you, and on behalf of the International Neuromodulation Society, offer whatever support we can give. My talk, of course, is on the changing history of neuromodulation. And while it has changed profoundly, I certainly want to start with the definition of neuromodulation, which is the electrical or chemical stimulation of the nervous system to alter and in fact restore neurologic function. And we can use either pharmacologic or electrical or digital drugs. And this is really becoming a field of neuro-restorative surgery. We can modulate the spinal cord and any of a number of regions depending on our needs and the potential applications. This has resulted in a tremendous growth and development of neuromodulation, and in fact is part of the reason for the changing history. There's been a tremendous proliferation of targets and applications from these earlier targets to a number of others, including applications not only that have become well established, but a number of different applications that seem to be on the cutting edge. Most recently, even the use of neuromodulation for the treatment of the inflammatory complications of COVID-19. So let's focus on chronic pain. And we know that over 100 million Americans suffer from chronic pain. Now almost 100 million are partially or totally disabled. And the costs of this care are over $600 billion per year. If we look just at Medicare costs alone, over $100 billion a year are spent to treat chronic pain. And this is not because Americans may not be very stoic. If we look around all Western countries, the number is $1.8 billion per million population. And one can scale up depending on these numbers in your local region or territory. So what we do know is that while neuroablative surgery has some role, it's largely been replaced by neuromodulation, which is testable, reversible, and has fewer complications. So the number of DREZ procedures like this I do has fallen to a bare minimum. But we're supposed to be talking about history. So let's talk about the history of neuromodulation. It dates back over 2,000 years, and the ancient Egyptians identified using electrical fish as a way of stimulating people's legs and treating a number of disorders, including arthritis and diabetic peripheral neuropathy. This is the electric torpedo fish, and they'd have people stand on wet sand over the fish, get multiple shocks, and this reportedly gave relief. There is a long and colored history going up through the 18th and 19th centuries of basically fraudulent uses of electricity to treat chronic pain. But really, it's been in the 20th century when the explosion of information, the understanding of electrical circuits, the nervous system understanding, and understanding applying exogenous currents to the nervous system, that we really developed an understanding of how neuromodulation could treat chronic pain. As everyone knows, this came to a highlight when Melzack and Wall reported the gate control theory in the 1965 in Science magazine. And all of you know this, but basically it's competition of large A beta fiber input and small A delta and C fiber input to the target cells, we can see labeled T on this diagram, and the balance of those inputs would determine whether or not pain information was transmitted to the central nervous system. Within 2 years, this was rapidly translated by Norman Shealy and his group in Cleveland to do the first spinal cord stimulation in humans. And at the same time, Bill Sweet and Pat Wall published their experience with peripheral nerve stimulation for pain, showing a tremendous rate of translation, a really tremendous advance of history in a very short period of time between theory and practice. We then, however, fell into a dead zone. And from 1967 till about 2010, there was very little done in the field, so history remained pretty static. The reason for this is that there was little or no competition, and now with several new competitors in the field, there's been an explosion of research and interest in spinal cord stimulation, and history has gone from static to rapidly accelerating. And during that almost 20-year period, 30-year period, you can see that one development was the 4-contact paddle lead. The use of transcutaneous transmission of power, the first implanted powered system, and the use of percutaneous leads, and finally the rechargeable IPG. Between 1967 and 2000, these were about the only major advances. But spinal cord stimulation has changed profoundly now and forever in the future. And I want to talk about several of these technologies, but I want to identify the change. The critical change in history has been that from the very beginning, spinal cord stimulation and pain-related neuromodulation therapies were really felt to be 50% effective in 50% of people or more. And that was the bad history that we have to improve on. The other history that we need to improve on is actually much more recent. Many of you have seen the article that was published yesterday or the day before in the MedTech News about the FDA identifying over 400,000 complications of spinal cord stimulation procedures and the need for us as a field to up our game. I am not certain that we haven't already done so, but it's certainly something we need to be very clear in improving so that history doesn't come to an end in this field. But back to the changing history. One is peripheral nerve field stimulation. We've done peripheral nerve stimulation since the very first days of neuromodulation in the late 1960s. Using small sensory nerves has been introduced in the late 1990s, but more recently we have stimulated smaller unnamed fibers, sort of the leaves and twigs on the furthest branches of the tree. The procedure, of course, is very straightforward. This is a picture from Giancarlo Barilot showing a patient with persistent localized pain after spinal fusion that was well treated with subcutaneous peripheral nerve field stimulation. Peripheral nerve stimulation has accelerated tremendously. It was virtually never done when I was training in neuromodulation. Now it is one of the more frequent procedures, although it has been adapted largely for treatment of craniofacial pain. This was then expanded to occipital neuralgia, stimulating both the occipital nerves and or the supraorbital nerves. This for supraorbital neuralgia, many articles for stimulating the occipital nerves for cluster headache, stimulating the supraorbital nerve for cluster headache, stimulating the sphenopalatine ganglion for cluster headache. And you can see there has been a tremendous growth in the use of peripheral nerve stimulation for many types of headaches, syndromes, and neuropathic pain. I have a particular interest in migraine headache, which is a remarkably common and overwhelming problem, even despite the introduction of newer classes of medications. And the first reports of this went back to the early 2000s. There were several highly successful uncontrolled studies, but 3 large randomized controlled trials, all 3 of which failed to meet their primary endpoint, all 3 of which showed that about 35 to 40% of patients had good to excellent relief, but did not again meet their primary endpoints. This gave us a big headache trying to figure out how to stimulate, and we looked to reports by some other physicians about stimulating at multiple sites, and we decided to do a study on what we called semiotic stimulation, which is just a sophisticated sounding way of stimulating wherever it hurts. And so we had patients identify where they had their pain, and they could get anywhere from 1 to 6 electrodes based on the distribution of their headache pain. This patient with bilateral occipital and supraorbital leads for bilateral, supraorbital, and occipital headaches. And we performed a study with 2-year follow-up, had an initial success rate in trialing of 92%, and a 2-year follow-up, 78% did good to excellent, 9% did fair and we considered failures, but the patients still were very happy with the results. And these results were roughly twice as good as the large scale controlled trials, suggesting that this may be the way to go in the future. To talk about things that have changed the history briefly of neuromodulation for pain. And I'm not going to talk about the basic science of any of these. I'm simply going to say that a large-scale randomized controlled trial of dorsal root ganglion stimulation demonstrated profoundly better results than spinal cord stimulation for patients with complex regional pain syndrome type 1 or type 2. If we look at the patients who had a successful trial, fully 93% of patients were successful at 3 months. This was significantly better than spinal cord stimulation, and these differences were maintained over 12 months and ultimately 24 months of study. And this is the plot demonstrating the high degree of superiority no matter how you cut the data. And instead of being in the 50-50 club, for the first time, we're seeing stimulation results of very high output, high degrees of pain relief. Here, for example, 70% of patients had 80% or more pain relief. And this, of course, was published in the journal Pain. So we also want to look at some of these other trials that have added to our information about how spinal cord stimulation works. And part of the historical change is that our understanding of how these devices work has become much more complex and multifactorial. Again, only talking about randomized controlled published trials. We have the Senza RCT, which was looking at 10,000 hertz spinal cord stimulation, a large-scale randomized controlled trial, which again, instead of somewhere around 50% relief, was 80% or more pain relief. I'm sorry, 80% or more patients getting 50% or more pain relief, changing the history from a therapy that worked half of the time to give people 50% pain relief or more. Now we're talking about, again, more than 80% chance of this happening. And again, we'll talk in a minute about how many got greater than 80% relief. These are the tornado plots that just give you a visual sense of not only how many more responders there were, but how much more their response was. And this is for back pain and leg pain. And if we looked at the results at 18 months and 24 months for back and leg pain, they are maintained. And this has been published in several high quality journals. Burst spinal cord stimulation, again, adding to our understanding of mechanisms where bursting can stimulate both the lateral pathways affecting the somatosensory components of pain and the medial pathways affecting the affective or emotional component of the pain. The BURST trial was a randomized crossover clinical trial, 1-to-1. These are the numbers in that trial. These are, again, the plot showing the statistical superiority for back pain, leg pain, or overall pain. The differences were clinically small, but with the further development of burst stimulation as developed by Dirk de Ritter, using much lower stimulation intensities has increased the effectiveness of bursting as well. Closed loop feedback, again, during stimulation, all kinds of spinal cord stimulation are plagued by the movement of the spinal cord relative to the electrodes. And because the distance is a critical factor in determining how much of the stimulation actually stimulates the spinal cord, we get broad changes in the amount of stimulation with any kind of spinal cord stimulation. When we sense the spinal cord stimulation effect on the spinal cord directly and then modulate it pulse by pulse to normalize it to the optimal amount of tissue stimulation, we eliminate these bursts of increase or decreased stimulation that occur with movement or breathing or coughing that significantly inhibit traditional spinal cord stimulation. And this was the randomized controlled trial comparing not really a true control. This is comparing patients with closed loop on or off, but both using evoked compound action potentials for programming. If we compare this to historical controls, we have 82% versus 60% versus about 47%, showing that just using ECAPs for programming does better, but you get much better if you then turn on the closed loop and use ECAPs. And so if we look here at the intent to treat analysis or the permanent implant set, we see a significant preference for closed loop stimulation. And this is largely because more time is spent in the therapeutic window. That is, if you give the patient the device and let them control it, they will turn the device down to avoid getting shocked. That is the above maximum. But by turning it down, they're spending a lot of time below the threshold needed to provide pain relief. And only about 60% of the time in this study were patients in the therapeutic window, whereas by turning on the closed loop, over 90% of the time they were in the therapeutic window and they never got shocked. And last of all, I want to mention restorative neuromodulation, which is a big historical change in this field, in that all of the stimulation that we've done so far has been for patients with chronic neuropathic pain. And this is for restorative neuromodulation has been designed for chronic mechanical low back pain, for which there is no other neuromodulation therapy. And so instead of being a palliative therapy, that is just a pain relieving therapy, as spinal cord stimulation is for neuropathic pain, reactivate therapy, which is stimulating the multifidus muscles, or in fact the nerves to the multifidus muscles, aims at restoring the function and strength of the multifidus muscles and ultimately decreasing this pain. And you can see that the curves are very different between a palliative and restorative therapy. With spinal cord stimulation, we see the biggest effect immediately, and then we hope to maintain that over time. Whereas with a restorative therapy, the therapy builds on itself as the underlying muscles improve and the effect becomes greater and greater. So again, there has been a large-scale randomized clinical trial that very recently led to FDA approval, which demonstrated a significant improvement in all of the variables except for the responder rates, that is the primary efficacy endpoint. But this would have been significant if patients who started taking narcotics and therefore were deemed failures were excluded because they started taking opioids for an entirely different problem, like a renal abscess or dental care or something like that. There were 6 of those patients, and if you eliminated those 6 patients, then everything that was evaluated would have been highly statistically significant. The effect matures and increases over time, whether we're looking at pain or if we're looking at disability. And as I mentioned, in this patient population, it's very highly effective. And this graphic won't work, but if you see the bottom left-hand corner of the orange area, that's the area where patients started. And if you see toward the upper right-hand corner of the darkest green area, that is where patients ended up, showing both a substantial improvement in both ODI and pain. So what we do know now is that we're no longer members of the 50-50 club. The history has changed, and now we can expect to see 80% or more pain relief in at least 50% of patients, and 50% more pain relief in 80% of patients, and in 70% of patients, 80% or more pain relief in these newer modalities. We also know that stimulation is a whole lot better than chronic opioids. If we look at the number needed to treat, that's about 1.5 for spinal cord stimulation, and it's about 8 for opioids. If we contrast that to the number needed to harm, we can see that we can do harm with strong opioids if we're treating only about 10 patients with strong opioids, whereas we have to treat almost 100 patients with spinal cord stimulation before someone is harmed. So for both safety and efficacy, stimulation has been demonstrated to be better than opioids. The future is very different, and the future from now has to build on what we've built on before, and with better neuroimaging, with nanotechnology, with active research into new applications, and some of the work that has been done on spinal cord stimulation for paralysis is breathtaking. And most importantly, the availability of good clinical studies using contemporary study designs in safety and efficacy. Neurorestorative surgery has unlimited potential, and it really paints for a great history of neuromodulation, not only to improve in pain, but to spread throughout the body for treating disorders that have been poorly treated in the past. Two quick things to remember while these studies are ongoing. Recently approved has been a device with an IPG that's the size of a dime. And it is powered transcutaneously, like we used to do in the dark ages, but advances in computer technology and engineering have allowed this to be a rapidly changeable, rapidly updated system that patients tend to like very much. Furthermore, our devices tend to get more and more expensive, and the majority of the world has limited resources. So I point to this reverse engineered DBS system from China, which was meant to sell for profoundly less than the existing devices in Asia. It's now sold for about half that price, and we need to be mindful of the cost of these devices to be able to provide access to our patients around the world who suffer so much. So I encourage you all to submit your work to our journal. As you know, Robert Foreman is the acting editor-in-chief until I finish with my presidency. And I thank you so much for your attention, your perseverance, and for your strength in dealing with these most difficult times.
Good morning, everyone. My name is Cass Amir-Delfin. I'm the Director of Medical Research at IPM Medical Group in Northern California. I'm also the Vice President of Pacific Spine and Pain Society, and it's my pleasure to kick off this PSPS annual meeting. My topic today is novel waveforms and frequencies in spinal cord stimulation. These are my disclosures. Spinal cord stimulation has been around for quite some time at this point, and the effective stimulation on the neurons is basically generating a one-to-one action potential. The first research into doing neurostimulation was started in the 1960s. Neuron response can be variable. It could be blockade, it could be desynchronization, it could also be novel responses that we don't even know about. Before we get into talking about novel waveforms and frequencies, we need to define the terms. Low frequency is anything between 2 Hertz to 1500 Hertz. For example, 40 Hertz is tonic or traditional spinal cord stimulation. 500 Hertz pulse train is burst as we know it. 1000 Hertz is called high density at this point, and differential target multiplexing is a blend of different waveforms and frequencies under 1200 Hertz. High frequency is defined as 1500 Hertz all the way up to about 100,000 Hertz. And ultra-high frequency, which is something that we've just started studying, can go all the way up to about 500 kilohertz. Waveforms can be sinusoid, square, pulse, or pulse width, and the pulse width for every one of these can also be very different. We're going to start with burst stimulation first. Burst stimulation pulse trains is a pulse train of 4 or 5 pulses at 500 Hertz, but that clump of pulses that come at a frequency of 40 Hertz. The idea behind burst stimulation is that it provides a different but physiological neuronal response, and it may attenuate the pain signal better. That was basically the working theory behind it that Dr. Dirk de Ridder, the man who started everything about pulse spinal cord stimulation, hypothesized when he started his animal studies. Burst stimulation definitely works on the lateral pathway, just like all the other spinal cord stimulation parameters out there, but it is thought that burst stimulation may also affect the medial pathway as well. The medial pathway may attenuate the suffering of the chronic pain patient. So the theory behind burst stimulation is that it not only affects the pain signal, but it also may affect the attenuation of the suffering, and the patients may deassociate from their chronic pain altogether. So in a double-blind, placebo-controlled study that Dr. DeRitter did some time ago before we started to do it here in the United States, he not only was able to show that there was significant, vast reduction with burst as well as tonic, but burst did better than tonic in his study, but he also showed that PVAQ scores, which is the pain catastrophizing scale scores, improved significantly with burst over tonic. So he also collected limbic system and medial pathway EEG data on these patients. Since then, we've done a randomized control trial. I've had the honor of being involved in the Sunburst study, the randomized control trial here in the United States, and a lot of other studies have been done, and just about all the studies out there show pain relief of about 50% across the board with burst stimulation. So this is obviously a step in the right direction, but we haven't seen anything beyond 50% in most of the studies that have been done. In fact, in the Sunburst study, with the 24-month data, giving the patients the option of using either tonic or burst stimulation, what we saw was that the patient's pain relief was about 50% or a little bit less at the 24-month mark. So we also looked at the effective component of burst in the Sunburst study. So the idea was for us to see if we can replicate the pain catastrophizing scales that we saw with Dr. DeRitter's study in a randomized control trial here in the United States. And in fact, we saw no change in the PVAQ scores in the Sunburst study itself, and we didn't even report it in the Sunburst study publication. Next is differential target multiplex SCS. By definition, differential target is when you use more than one target for spinal cord stimulation, and multiplex is that it's more than one signal. So it's a blended signal at multiple targets over the spinal cord and the dorsal column. This is designed for patients with chronic low back and leg pain, and it's been in the works now for about 12 years, starting with bench studies and animal studies, and we are now in the middle of the randomized control trial here in the United States. The idea behind differential target multiplex SCS is that 90% of the neuronal cells within the spinal cord are actually glial cells. In fact, the ratio of glial cells to neurons is about 12:1 in the spinal cord itself, and that ratio changes from segment to segment in the spinal cord. Glial cells have been implicated in the development and the maintenance of chronic pain, and they also respond to electrical stimulation. So they may very well be an excellent target for spinal cord stimulation. So in effect, we know that glial cells are involved in chronic pain. We know that we could potentially affect them with some type of electrical stimulation. So should we use spinal cord stimulation to control glial cells? Dr. Ricardo Vallejo and some of his colleagues did a lot of animal studies and bench studies to see if differential target multiplex SCS could potentially do better than tonic spinal cord stimulation or higher frequency spinal cord stimulation at 1,000 hertz. And what he was able to show that, in fact, differential target multiplex SCS is more responsive and it's more effective than tonic or 1,000 hertz itself. But the more interesting thing that he was able to show is that the genetic expression of the animals that had effectively been programmed to have chronic pain started to normalize towards a normal state without pain. So if you look at these graphs here, they're a little bit complicated, but the left column is actually the normal genetic expression of an animal without pain. And all the other ones are the genetic sequencing of animals with pain that had been stimulated with tonic at 40 hertz, 1,000 hertz, and also differential target multiplex or DTM. And as you can see, the DTM subjects, the DTM animals' genetic expression started to approximate what we saw in the non-pain state altogether. So in effect, this type of spinal cord stimulation could potentially affect the genetic expression of the patients and also the animals that could potentially provide us longer-term pain relief. This also happens in the neurons themselves outside of the glial cells, and as you can see in the differential target multiplex subjects, the genetic expression approximated more of the non-pain state than any other spinal cord stimulation therapy. Animal studies are all great for scientists, but we're all clinical people and we treat patients on a daily basis. So we look at randomized controlled trials as our best quality studies to see how the patients do on a short and long-term basis. The DTM-SCS randomized controlled trial is a multi-center study that has been going on here in the United States. And we have the 3-month data here, but from what I understand, the 12-month data has already been collected and is going to be presented over the next few months. But the study was a simple study with 2 arms, one the tonic arm and the other one being the DTM SCS arm, and the subjects were randomized to the 2 arms of the study. Defining responder rate as 50% or more, the tonic arm of the study showed a 51% responder rate at 3 months, which was the primary endpoint of the study. 51% is basically on par with everything we've seen in our peer-reviewed literature with tonic spinal cord stimulation, but the DTM responder rate was actually an impressive 80% at the 3-month mark. Looking at the tornado charts, you can see how both arms of the study did quite well, but looking at the high responder rate, patients who had 80% or more pain relief, there was 63% of those patients in the DTM arm versus 28% in the tonic SCS arm. And these numbers do, the tonic spinal cord stimulation high responder rate does correspond to things we've seen in other peer-reviewed literature. Looking at the VAS scores for low back, we had a significant reduction in the low back pain VAS scores in both arms of the study, but obviously the DTM arm did far better with a 74% reduction in the VAS scores at the 3-month mark versus 46%. For leg pain, we saw similar results. The baseline pain was at 6.18, and it was reduced down to about 1.17, which is a 72% reduction in the patient's leg pain versus 59% for tonic spinal cord stimulation. Pulse stimulation pattern, or PSPS, is also something new, which is a blended recipe of waveforms and frequencies that is being tested at this point in Australia, and we just started a randomized controlled trial here in the United States as well. So this is multiple mechanism of action in a single waveform. There's narrow pulses with low threshold fibers, dorsal horn roots, and dorsal horn and dorsal roots, stimulation efficiency, and priming the glial cells. It also affects the high rate train onset and offset with increased fiber recruitment. Long train charge delivery is also one of the attributes of PSP, with affecting the high threshold fibers, the dorsal column, and also the lateral as well as potentially the medial pathway, although we haven't seen the PVAQ scores for this particular therapy yet. Low rate train onset and offset allows for accommodation of the medial and lateral pathway, and it makes the whole thing very power efficient, which gives us energy efficiency for the type of stimulation we would be engaging with this type of waveform and frequency. The idea of PSP came about in 2015. The animal models were tested in 2016. The chronic study, the NPower study, which was first in human, is ongoing in Australia. Dr. Paul Verrills is the primary investigator for that study. And as I said, we just started the randomized control trial for the NPower study here in the United States, and I'm proud to be an investigator in that study as well. Now, the NPower study from Australia does have some preliminary data. This is a prospective, multi-center, open-label clinical trial. It's at 5 sites in Australia. There are 32 study subjects that have been implanted, and 21 have actually gotten to the 3-month mark. There's ongoing follow-up with these patients, and they will be followed all the way up to 1 year. What we saw in these patients with low back and leg pain was a significant reduction in their pain. The baseline pain was about 6.6 for low back and 6.7 for leg, and there was a 74% reduction in the low back pain, followed by 80% reduction in the patient's leg pain. The responder rates are quite large, again, defined as 50% or pain or more pain relief. The responder rate for low back was 82%, and the responder rate for leg pain is actually 83%. The NRS scores were reduced both for low back and legs to impressive numbers. The latest numbers we have for an N of 7 at 12 months is about 1.45 for low back pain and 1.12 for legs. Granted, this is all very early data. The N's aren't that large yet, but we'll have 12-month data on all of the patients in the near future. But it's also very exciting with the kind of pain relief that we're getting. Next is high frequency, which is 10,000 hertz at this point. High frequency waveform, if it's scaled, it's actually a waveform that is designed to be a little bit different than what we've seen in spinal cord stimulation so far. The pulse width is 30 microseconds, and the thought behind high-frequency spinal cord stimulation is that high frequencies may actually allow us to use lower amplitudes and potentially affect the neurons far better in a direct manner. There were some preliminary studies done with high-frequency spinal cord stimulation at 10,000 hertz, and there was a randomized control trial that was done in 2012 here in the United States. I was also an investigator in this study. 198 subjects were randomized to tonic spinal cord stimulation and high-frequency spinal cord stimulation for low back and leg pain. At 24 months, we saw significant pain relief in both arms of this study, but obviously 10,000 hertz did far better than tonic spinal cord stimulation in the subjects that we tested. But how is it that this happens? There's been a lot of animal studies done over the past few years. The company that manufactures 10,000 hertz has invested quite a bit of money to understanding the mechanism of action for 10,000 hertz SCS. And what they've found so far is that there may be direct neural inhibition of the wide dynamic range neurons that could potentially translate into the kind of pain relief that we've seen with this technology. The idea behind 10,000 hertz, the idea behind any spinal cord stimulation is for us to be able to affect the inhibitory neurons without affecting the excitatory neurons as much. So the more excitation of the inhibitory neurons we have, the better, but we don't want to excite the excitatory neurons. In the animal studies done by the neuroscientists around the world, you can see how at 1,000 hertz, there is some excitation of the inhibitory neurons without the excitation of the excitatory neurons. But it's really not that much and not that impressive. At 5,000 hertz, we see an uptick in both inhibitory and excitatory neuron stimulation, but it isn't until 10,000 hertz when we start to see a significant amount of stimulation in the inhibitory neurons, which are the neurons that we want, without the excitation of the excitatory neurons. And this may be why it translates to the kind of pain relief we see clinically with 10,000 hertz spinal cord stimulation. The company has also started doing blending of various waveforms and frequencies. They've done some preliminary studies using burst stimulation along with 10,000 hertz and tonic stimulation along with 10,000 hertz in a blended form to see if the clinical outcomes could potentially be augmented. The preliminary studies were done in Australia. They surveyed about 500 patients, and about 5% of the population were subtherapeutic, 26 out of 493, in fact. And these patients were exposed to frequency pairing using burst and 10,000 hertz or using low-frequency tonic at 40 hertz blended with 10,000 hertz. And the responder rates defined as 50% or more pain relief improved from 17.4% all the way up to about 60%, which is an encouraging number and an insight into how blended waveforms may be the way of the future. So in conclusion, there's an increasing number of choices in the field of neuromodulation. Novel waveforms and frequencies may or may not be better. It's really important for all of us to look at the scientific evidence to see what we have. We're all clinicians, and we're all used to listening to the marketing rhetoric that comes out of every company, but I think it's our responsibility to our patients to read the papers and the scientific evidence itself to see what's happening with every single type of spinal cord stimulation. Long-term outcome evidence is imperative for a clinical decision. We can't be looking at 3-month data. That's really good for scientists, but I'm more interested in 12 and 24-month data in order to be able to choose the right thing for my patients. And randomized controlled trials continue to remain the gold standard for scientific assessment. Scientific evaluations is the only tool we use, and I encourage everyone to be able to do that for themselves to be able to make the right decision for their patients. Thank you so much. Hello, my name is Cass Amir-Delphin. I'm an interventional pain physician in Northern California. I'm also the Director of Medical Research at IPM Medical Group, and I'm the Vice President of Pacific Spine and Pain Society. My topic today is 10,000 Hertz neuromodulation for the treatment of painful diabetic neuropathy, which is a multi-center randomized controlled trial. As all of you know, diabetes is becoming an epidemic in the United States and around the world, tied into obesity. And diabetic neuropathy is becoming a very big problem. The medications that we have for the treatment of diabetic neuropathy are dismal at best. The kind of efficacy that we get from medications is somewhere around 20 to 30% responder rates. So we've all used spinal cord stimulation to treat peripheral neuropathy in the past, but the question that we had in our mind was whether we can actually treat painful diabetic neuropathy specifically with 10,000 hertz. So this study turned out to be the largest study ever done in a randomized controlled manner in spinal cord stimulation. The study is now closed. 216 subjects have been enrolled in the study and randomized to 2 arms, conventional medical management or conventional medical management along with 10,000 hertz SCS. We have the primary endpoint data here today. Dr. Erica Peterson is the primary investigator of this study, but I'm also an investigator in this study, and I'm proud to share with you the primary endpoint data so far. These are my disclosures. So the methods of this study were really simple. Painful diabetic neuropathy patients who were refractory to conservative treatment. Spinal cord stimulation has been established as a non-pharmacological reversible therapy for the patients. We wanted the patient's hemoglobin A1C to be less than 10, which in and of itself was an encouraging feat because we typically use hemoglobin A1C of 8 as our cutoff in our clinics. And the BMI needed to be less than 45 for these patients. There were 18 U.S. centers, 216 patients were enrolled to a one-to-one randomization. The conventional medical management patients are allowed to cross over at some point in the study as well. Independent medical monitors reviewed all the subjects, and we followed these patients all the way through 12 months. And in fact, the 12-month subjects have now reported, and the data is being tabulated for us to present it in the near future. So for the 3-month follow-up, we assess pain, quality of life, and also the patient's neurological function, because in the feasibility study, we did see some sensory improvement in a portion of the subjects. This is a very busy table showing the demographics of the patients, but there's a couple of very important points here. First of all, these patients weren't just diagnosed with diabetes. Just about all of them had had a diagnosis of diabetes for greater than a decade. Aside from that, the peripheral neuropathy had been present for at least 5 years in most of these patients. As you can see in both arms of the study, the average years since diabetic neuropathy started to show up is about 7 years in these subjects. The other thing that's really important is in the right table, right in the middle, you can see the infection rate. With diabetic patients, we're always concerned about the infection rate being higher. Despite the fact that we use the hemoglobin A1C of 10 as the cutoff, the infection rate was actually less than what we've seen in our peer-reviewed literature. It's very, very interesting that only 1% of the patients did present with infections. If you look at the VAS scores of these patients, we had some significant improvement of the painful diabetic neuropathy patients. We started with a VAS score of 7.6 at baseline. It was reduced down to about 1.7. There was also some, modest improvement of the patient's pain in the conventional medical management arm, but as you can see, that they went from 7 to about 6.5. Really not that impressive, 5% reduction. Looking at the tornado charts of the responder rates, you can see that 89% of the patients in the 10,000 SCS plus conventional medical management arm actually had responded to this type of therapy, which is unprecedented. We've never really seen anything like this, and it was incredibly impressive. There was a 7% responder rate in the conventional medical management arm as well. Sensory assessments, is a big part of this study. We're doing these thorough sensory examinations on these patients, and 72% of the patients so far have actually shown improvement in their sensory presentation at the 3-month mark. Again, an unprecedented feat. We've never seen sensory improvement with any type of spinal cord stimulation, and it really shows that this is a step in the right direction in changing these patients' quality of life. One of the stories that Dr. Sean Lee, who was involved in the feasibility study, loves to tell is the fact that one of his patients came in one day and he was talking to him about how much improvement he had, and he said, well, let's put it this way. I haven't felt the coldness of the tiles in my bathroom in over 10 years. This morning, I felt it. And that's just a testament to the kind of sensory improvement we've seen in a significant portion of these subjects. Quality of life has improved across the board. The patient's trouble falling asleep improved. Their awakening improved in the SCS arm, and being awakened in the morning with pain also improved significantly in the 10,000 Hertz SCS arm versus conventional medical management. The 6-minute walk test, which is something that we now are starting to use as a standard to assess the patient's function, also improved significantly in the 10,000 Hertz SCS arm. Quality of life improvement was quite significant. You can see that 67% of the patients reported a significant improvement in their global impression of change. The clinicians reported 72% in the 10,000 Hertz SCS arm plus conventional medical management. There wasn't a significant change in the impression of change for the conventional medical management arm. There were quite a few investigators that have been involved in this study. I'm proud to have been one of them. I'm there on top left. I want to thank Dr. Erica Peterson for being such a wonderful primary investigator in this particular study, and we look forward to the 12-month data. This is really a groundbreaking information that could really potentially help our painful diabetic neuropathy patients far beyond anything we've done for them so far. Thank you all so much.
Good morning, everyone. I'm Dr. Krishnan Chakravarthi, and over the next 10 to 15 minutes, I'm going to be helping to talk about glial cell activation and spinal cord stimulation. For those of you who don't know me, I'm actually an assistant clinical professor at UCSD Health, as well as I practice at VA San Diego Healthcare. You know, I think this field, especially with the integration of the neuroimmune effects on neuromodulation, has become a really important part of the future of where different therapies are going to be really looking at understanding mechanism of action. So these are my disclosures. Obviously, we're happy to have worked with a bunch of different companies that are helping to advance these therapies, as well as founded several of my own startups out of UCSD over the course of the last 3 to 5 years. You know, I started this talk thinking about just a reflection of all of us that have been in the neuromodulation space. And this was a really interesting article that came out in Scientific American about the role of the future in pain therapies. And when you look at this interesting diagram, what really talks about is how far we have come in trying to develop individual therapies, but where really the future is, similar to where oncology was about 15 years ago in the advent of personalized medicine. And that concept really is developing indication-specific clinical trials to help clinicians make decisions about who the right patient is for the right therapy. And as we look at the neuromodulation space, especially given all the newer therapies that are currently out there, the emphasis on science and data helping us to really get down to identifying the right patient is really going to drive how we see the field in the next 5 to 10 years. And so when you look at kind of the pain mechanisms, the reality is that ultimately you're delivering an electrical current to the spinal cord. But where in that treatment paradigm or pathway we're really delivering that current has a definitive effect on not just neurons, but really the larger microenvironment. So if you look at this, you know, you think about how does pain really transmit, right? You look at the Wall and Melzack gate control theory, which was really the advent in the late 50s that led to the first set of neuromodulation therapies in subdural lead placement. But over the course of the last 50 years, what have we understood is that the actual process of pain transmission starts all the way from the peripheral nervous system all the way to the cortex. So one part of that is over the course of last 10, 15 years, our field is really focused on understanding what happens when electrical current affects neurons, what happens to individual action potentials as they're up and down regulated. But the truth is that the spinal cord isn't just constituting one single cell type or one action potential between neuron to neuron. There is really a truer, larger microenvironment that constitutes the interaction between neurons and glial cells. So the foundational work to understand anything about why glial cells are critical and important is really looking at understanding the cross-sectional slices on the spinal cord. So what people were doing was what are called histopathology stains. They would take slices of the spinal cord and stain different cell types. And what they observed was that really the proportion of glial cells to neurons far outweighed our understanding. So to assume that simply stimulating something in the spinal cord doesn't have an effect on the other cell types is something we need to drastically change our perception and understanding. And when you look at a lot of the gate control theory and the articulation of whether it's HF10 therapy, whether it's burst therapy, looking at the different laminal structures in the spinal cord, the reality is that these glial cells actually traffic across the entire subtissue. So how does glial cells really affect the neuroimmune response and pain? I trained at Mass General. There was a very famous researcher, Clifford Wolff, who actually spent the latter part of his entire career looking at the effects on glial cells and central sensitization. And the thrust of that work over a span of 15, 20 years, which the pharma world has certainly expanded a lot of their drug options on looking at glial cells and toll-like receptor 4, is this concept that the interaction with glial cells and neurons has a critical component to the maintenance of pain. And we've actually understood that looking at science and mechanisms across, that receptor pathway is really driven by the paracrine cytokine responses that these glial cells secrete to these neurons that maintain the same action potentials that we are recording up and down on stimulation. So what happens is that it's really fascinating. And microglial cells, by and far, whether you look at our understanding of when we went through medical school, the common moniker for glial cells were macrophages. And to really understand the importance of that, you have to understand the context with which they play a role in the immune response. So whether you're looking at their interaction with viruses, bacteria, and or something as chronic pain, inflammation really has 4 steps, and we call this the 4R model: recognition, recruitment, response, and resolution. So the challenge here is that when you have an acute injurious event that causes injury, that causes pain, that the body is teleologically and evolutionarily, that's the expected response. But for a lot of patients that have chronic pain, what we have really understood is that there is some form of phenotypic alteration to these cells that propagates this chronic response over a certain time course that we're supposed to actually recover. And when we actually look at glial cells in general, what we're finding is that they have very specific identification phenotypes, what are called classical and alternative activation. So classical is when they're very pro-inflammatory, and alternative is what essentially allows them to mitigate that initial response or inflammation response to down-temper that. So the hypothesis really is that there are a lot of central sensitization is driven by this pro-inflammatory phenotype of macrophages that became predominantly dominant, or glial cells when they're put into the central nervous system that don't really revert back to the native phenotype. So the question is that if you look across different etiologies of pain, CIPN, small fiber neuropathy, CRPS, it is clear that inflammation and the pro-inflammatory glial cells are a critical driver to the maintenance of pain. The question then we have to then ask is, well, how effective is stimulation in terms of targeting these cells? Do they, in fact, change their phenotype in response to stimulation? So this was a lot of the foundational work that was done in the 80s, where they were really looking at how does electrical current change the phenotypic alteration of these cell types, and also what type of cytokines or chemokines they secrete. And on stimulation, what they effectively noticed was that these glial cells essentially transmit or release different neurotransmitters on stimulation versus off. So I know as clinicians, we always balk at the relevance of preclinical data to how it drives our clinical practice. But the reality is that a great majority of drugs today and or therapies today started with preclinical work. Why? Because the ability to control certain parameters as well as define mechanism has really let the foundation of a lot of that work in the laboratory. So what you're looking at is what's called a sciatic nerve ligation model. Typically in these preclinical models, we ligate the portion of the sciatic nerve that creates what we call hypersensitivity or nociceptive or neuropathic pain. And what you're essentially measuring is the effect of a treatment in reducing or upregulating that pain. And so what the course of a decade worth of work was looking at these different parameters on how specifically what we look at when we're putting electrical current, whether it's pulse width, amplitude, frequency, and what that effectively does to the actual glial cells in the context of pain modulation. I will comment on something that I think the other really interesting part of where the science is going. I think we have, for a long time as clinicians, the other major challenge that is facing our field today is how do we get out of the subjective assessment for VAS score into something that's truly objective measurement. And the reality is that there are a lot of things that we can potentially measure. In the old days, when they used to do even today's clinical trials in pharmacology, we'd look at single advent up and down regulation of molecules as a way to assay an effective therapy. But really the next evolution in that is really looking at large-scale genetic analysis that looks at up and down expression of different proteins on stimulation. So what really led to the work and what you're going to be seeing clinically in the next 3 to 5 years, a lot of adoption of this therapy, is that what they really did is essentially looked at different parts of what you're delivering as stimulation, pulse width, amplitude, frequency, and they looked at actual genetic reversion and expression changes on these microglial cells in the spinal cord, and also all of the different players in that spinal cord, inclusive of the neurons that they're interacting with. So what would you predict? You would predict that if in fact your therapy was doing what it's supposed to do, your genetic expression profile would correlate with your objective pain assessment, bringing it back to baseline as a reflection of therapeutic efficacy. We have never seen anything like that developed in the space for a very long time, because this is the first time you're talking about developing a therapy based on an objective measurement of how you characterize pain. So really, once you've defined what is in the pain state versus a non-pain state, then you're really looking at modulating these different parameters to bringing it back to the non-pain state. And how did they do that? They really looked at whole genome sequencing expression across all the different cell types as well as holistically across the spinal cord. So what you're really looking at is this is called a gene heat map, and you're comparing low rate, high rate, and glial cell targeting with a combination of low rate and high rate, and really looking at, if you bring these parameters together, how effective is it to bring the genetic expression back to baseline. And that's based on a sense of correlation, right? The higher the correlation back to baseline, the more effective the therapy is. But it's not just about genetic expression. Really, the holistic part of this is genes get expressed into protein. And that protein then eventually translates into the clinical aspects of what you observe. So classic example, when we have an infection, why do we have a fever? Because you upregulate certain parts of your cytokines that essentially increase your thermal upregulation to fight infection. Similarly, we really are starting to look at, it's not just an up and down regulative of these gene expressions. What happens to the proteins that are downstream to that in terms of stimulation? And so this is actually GFAP gene expression protein. What they were really looking at is GFAP being a marker for pro and anti-inflammation with specific to glial cells. Do they up and down regulate upon improvement or down regulation of the gene expression? And they found that there was some consistency among that. So, you look then at the 3-month data set for a lot of where they try to apply this clinically to taking all of the preclinical work and putting it into the clinical setting. You have this classic example of the 50-50 club going to the 50-80 club, where you're going from a 51% responder rate to an 80% responder rate, and obviously 60% profound responder rate, which at the end of the day, the element of this is essentially saying that at the heart of translational research, what we're really going to be seeing is if we can effectively map genetic expression as a correlation to improvement in VAS score, the challenge clinically in the neuromodulation space is really therapy durability. There is clear evidence, if you look at the data sets across the last 15, 20 years, that explant rates have become one of the biggest issues as clinicians that we're facing. So what's exciting about this is really for a lot of the younger folks and fellows that are really thinking about this is imagine probably in 5 to 7 years, we're going to really be talking about using genetic expression changes as a prognostic indicator of who should be in a trial, as well as long-term therapy durability. So I think it really, I think we as clinicians have got a major responsibility. As more and more therapies get out there, we need to consistently emphasize the importance of science and data driving clinical decision-making. And I think the challenge in that is with our busy practices, how much relevance is this going to have in how we see the actual application of these therapies? But the truth is, I think we're at the point as we continue to develop this that it's going to be a critical part in how we apply future neuromodulation therapies. Thank you, and questions.
Good morning. This is Dr. Dennis Patterson coming to you for the annual PSPS conference. I want to thank you for joining us this morning. I am a physical medicine and rehabilitation doctor who specializes in interventional pain management based out of Reno, Nevada. And today I'm going to be talking to you about the evidence basis of dorsal column stimulation and the NAT guidelines. These are topics that I could probably do, an hour presentation on each. So I'm going to focus mainly this morning on the evidence of dorsal column stimulation and then reference the NAT guidelines for you to reference later. Here's my contact information. I'm always available anytime you email me or text me if you got my number. I usually get back to you pretty quick, so feel free to reach out to me if you have any questions about today's presentation. And as always, here's my disclosure slide. And as I said, I'm gonna cover the evidence basis of dorsal column stimulation. And as I stand here today, I think about modern stimulation. I think about traditional stimulation, or i.e. tonic stimulation. I think about what we're currently doing, or the evolution of it, which has been high frequency stimulation in alternative waveforms. And then I think about what are the future possibilities, or what research do we have that's emerging. And so today I'm going to cover kind of those 4 topics to show you the articles that I think should be part of your library and you should reference as the foundation of stimulation that we do today. So let's talk about traditional, or the foundational evidence that's out there. And I think you got to start with the North et al. Articles, and this is, there's 2 of them that I'd like to reference today. The first one is from 2004, and this is spinal cord stimulation versus repeat lumbosacral spine surgery for chronic pain. This was a prospective randomized controlled trial. It followed 50 patients who are candidate to have a reoperation, and it randomized them to either receive a spinal cord stimulation trial with implant, if successful, versus the reoperation. Patients at 6 months who are unhappy with their treatment could cross over to the other arm. And success was based off of self-reported pain relief and patient satisfaction. So the study endpoints were to look at crossover rates, success at their last follow-up, and improvement in the patient's daily activities, neurological status, and medication use. And the criteria for success was at least 50% pain relief and patient satisfaction with treatment. So if you look here, this is how the patients got randomized. And when you look at the results, you look at the crossover rate as the primary outcome, and you see that patients who got randomized to a reoperation, greater than 50% of them ended up crossing over to the spinal cord stimulation arm. patients who got randomized initially to spinal cord stimulation, only 20% of them crossed over for a reoperation. When you look at the long-term outcomes, what you see is that only 12% of the patients who got randomized to the reoperation ended up having success, and 0 of the patients who failed the spinal cord stimulation and went for a reoperation had any improvement in their condition. If you look at the spinal cord stimulator arm, patients who are randomized to that, about 50% got better with stimulation. And the patients that crossed over from another back operation to the spinal cord stimulator arm, was about 45% of those ended up improving. And so this kind of goes back to why we always reference the 50-50 club, because about 50% of patients who end up with spinal cord stimulation end up improving. If you look at this slide, this just shows the difference in function and medication use. There was no statistical difference basically in function between the two arms. But if you look at it closely, there was a difference in opioid use long term. Patients who got a reoperation had a 42%, or 42% of them ended up on increased opioids compared to the spinal cord stimulator arm, where only about 10% ended up with an increase in opioids long term. So the clinical summary for this paper was that spinal cord stimulation was more effective than reoperation as a treatment for persistent radicular pain after lumbosacral spine surgery. And in a great majority of patients, it obviates the need for reoperation. So in 2007, North et al. Kind of did a follow-up study on this, and this was, once again, they're looking at spinal cord stimulation versus reoperation for failed back surgical syndrome. But this time, not only were they looking at patient outcomes, but they're looking at the cost effectiveness to see which treatment was more cost effective. So once again, we have a randomized controlled crossover study. This study followed 42 patients who, once again, were candidates for a reoperation, and then they got randomized either to a spinal cord stimulation or a reoperation arm. And once again, if patients were unsatisfied with their treatment, they could cross over at 6 months. Outcome measures were to look at the crossover rate, success at their last follow-up, and finally, the cost effectiveness of each treatment. So here's your 42 patients who got randomized to 21 patients to spinal cord stimulation and 21 patients to a reoperation. And what we see here is that out of the 19 patients who followed through with the spinal cord stimulation, 7 out of 14 had success, and that was a cost to the system at $48,000. If you look on the right-hand side, the 21 patients who moved forward with a reoperation, only 2 out of 8 had success, and at $105,000 cost to the system. If you look at the patients who failed a spinal cord stimulation trial and crossed over to the surgical arm, 0 out of 5 of them had any success at a cost of $250,000 to the system. If you look at the ones who failed the reoperation, 5 out of 13 did well with spinal cord stimulation, and the cost of the system was $118,000. So the summary of this article was that spinal cord stimulation was less effective, or was less expensive, but more effective than reoperation in patients with failed back surgical syndrome, and it should be the initial treatment of choice, and that SCS is more cost effective than patients who undergo a reoperation, and that you should also consider patients who fail a spinal cord stimulation. In the last 2 studies we looked at, reoperation was unlikely to succeed. The next article I want to highlight is from Dr. Kumar. This is spinal cord stimulation versus conventional medical management for neuropathic pain. And this was a multi-center randomized controlled trial in patients with failed back surgical syndrome. So the goal of this study was to test the hypothesis that spinal cord stimulation, in addition to conventional medical management, was more effective for failed back surgical syndrome patients than just conventional medical management alone. Their primary and secondary outcomes were to look at patients to see if they achieved at least 50% pain relief for their back, for their lower extremity pain at 6 months. Secondary outcomes were to look at improvement in back and leg pain, health-related quality of life, functional capacity, change in use of pain medication and non-drug therapy, and the patient overall satisfaction with their treatment. So this study randomized patients to both arms. And what we saw here is, if you look at the top of the slide, we see change in VAS was significant for the spinal cord stimulation and conventional medical management. Once again, we see about 48% of patients show that an improvement versus 10% for conventional medical management alone at 6 months. When you break it down to leg versus back pain, which is graphs B below, that shows that there was a statistical difference in lower extremity pain relief with spinal cord stimulation versus conventional medical management alone. And then there was a small difference in overall change in VAS for lower back pain. Overall, the treatment group with spinal cord stimulation had an improvement in function at 6 months in all categories versus conventional medical management, which had, in some cases, the patients were less functional 6 months out. And overall, we saw a decrease in disability in the spinal cord stimulation treatment group versus the conventional medical management group at 6 months. So this study said that compared to conventional medical management alone, spinal cord stimulation improved pain relief, quality of life, functional capacity, and patient satisfaction in selected patients with neuropathic pain who suffered from failed back surgical syndrome. The next study I want to highlight is from Dr. Kemmler. This is a spinal cord stimulation in patients with chronic reflex sympathetic dystrophy. And basically, this was a prospective randomized controlled study to determine whether patients who suffered from reflex sympathetic dystrophy would improve with spinal cord stimulation with physical therapy versus physical therapy alone. Outcome measures were looking at the influence of treatment on their intensity of their pain, their global perceived effect, functional status, and health-related quality of life. And if you look at their 6 months, the 36 patients who went through this, 24 got randomized to the spinal cord stimulation and physical therapy arm, while 12 got randomized to the physical therapy arm alone. And what I've circled here at the top is where there was improvement. So it was an overall improvement in VAS and perceived quality of life. But if you look at function, whether it broke down into the upper extremity or lower extremity, there was no difference in functional outcomes between the groups. Breaking it down further, if you look at overall pain scores, you'll see at 6 months the spinal cord stimulation with physical therapy group, their VAS decreased, while the physical therapy group alone, their VAS was unchanged or slightly increased. And then looking at the overall global perceived effect, you'll see that the spinal cord stimulator group thought that their condition was improved or much improved at 6 months compared to the physical therapy group, where a majority of patients still thought their pain was worse or not improved or not worse, unchanged. So to summarize this article, it basically shows that carefully selected patients with chronic reflex sympathetic dystrophy, electrical stimulation of the spinal cord can reduce their pain and improve their health-related quality of life. So now I want to get to stimulation that we're using over the last decade. And I think the first article I want to highlight is on high frequency, or HF10. And this is the Senza study. And this article, or this study, was a prospective randomized controlled trial that was designed to assess whether or not high frequency stimulation was non-inferior, and secondarily, if it was superior as compared to traditional low-frequency spinal cord stimulation in patients who suffer from intractable back and lower extremity pain. Key outcome measures were to look at VAS for the back and leg, their Oswestry Disability Index, global assessment of functioning, and subject satisfaction. And here is the outline of the study and how patients got randomized to each arm. And here is the overall table showing outcomes. And what I want to highlight here is that if you look at disability scores at 12 months in the high frequency group, that about 62% of those patients had minimal to moderate disability versus only about 45% of patients with the low frequency stimulation at 12 months. And then if you look at overall patient satisfaction at 12 months, you'll see that 55% of patients were very satisfied with high-frequency stimulation, while only 33% of patients with low-frequency stimulation were very satisfied at 12 months. And then if you look at this slide, this shows the overall improvement in pain for the lower extremity and back compared to, from high frequency to low frequency, and you'll see that high frequency patients had greater pain relief for both. So basically, this study provided the first scientific, rigorous, randomized controlled trial demonstrating the superiority of HF10 therapy over traditional spinal cord stimulation and long-term treatment of back and lower extremity pain. So now I want to transition to alternative waveforms, and specifically burst DR. And this is the Sunburst study. And basically, this was a randomized, controlled, unblinded trial with two distinct phases. Essentially, these are patients who had a positive tonic stimulation trial. They were randomized to then have 12 weeks of tonic stimulation after they were implanted, and or burst DR. They would cross over, and then at that point, they had an open label phase at which each participant could choose a waveform to move forward with for pain relief. This is the outline of the study. And what they showed is that patients, the burst DR waveform was non-inferior to traditional stimulation, and it ended up being superior, and overall patients who chose the burst DR had better improvement in VAS, and that included the trunk and lower extremity. And if you look at preference per patient on what waveform they preferred, we see that about 69% of patients preferred burst over tonic. But it is important to point out that if you look at pain relief helping both patients, even though there were more patients who thought burst DR helped their pain, 50% of patients who got stimulation thought that tonic did help their pain as well. And then at the end, if patients were asked to put their preference to what they liked, we see that about 70% of patients picked the burst DR waveform for stimulation. There was a small percent of patients, about 20%, who did prefer tonic stimulation, and 10% of patients had no preference. And the summary for this article is that it demonstrated that burst spinal cord stimulation is safe and effective, and it is non-inferior, and is also superior to tonic stimulation for the treatment of chronic pain. And then I just want to highlight some things that are an article that was recently released that I think is a possible future consideration. And this is the EVOKE study. This was a multi-center, double-blind, parallel arm, randomized controlled study at 13 investigational sites. And basically what they're looking at is closed-loop stimulation to help chronic back and lower extremity pain. And so, as we know with dorsal column stimulation, you have fixed leads that are providing stimulation through to the spinal cord. The spinal cord is able to move, and so therefore stimulation based off of patient positions can change. In an open loop system, the stimulation based off patient positioning will vary in intensity for that patient, but in a closed loop system, the system is able to adapt and turn the stimulation up and down to make sure that the patient has the same intensity of stimulation through motion. Here is the randomization for the trial. And kind of what I want to point out here is that we see that at 12 months, compared with looking at the closed loop versus open loop, we see that about 80% of patients in the closed loop had at least 50% pain relief for their back and lower extremity, compared to about 60% for open loop stimulation. And then if you look at the high responder rates, you'll see that it was about greater than 50% of patients in the closed loop got greater than 80% relief, while only about 35% of patients in the open loop stimulation. And the last thing I wanted to point out was the amount of time that patients were in their therapeutic window, and that's where stimulation wasn't too high or too low. And we see that patients in the closed loop at 95% of the time were in their therapeutic window, while only 50% of patients outside the clinic in the open loop study were in their therapeutic window, with majority of them, greater than 50%, being at the lower end of the threshold. So basically, the summary of this article is that closed loop stimulation provided significant or greater meaningful pain relief at 12 months versus open loop stimulation, in that greater spinal cord stimulation associated in the closed loop, or greater activation seen in the closed loop group suggests a mechanism explanation for the superior results, which aligns with the putative mechanism of action of spinal cord stimulation and warrants further investigation. And then lastly, since I'm running out of time, I just wanted to highlight the NAT guidelines or reference them for your future perusal. Essentially, the NAT guidelines is from our brother society, the INS, and this is basically a group of physicians who are experts in spinal cord stimulation, and they put together some guidelines to guide best practices moving forward. And so there are several articles out there. There are some on the treatment and complications of neurostimulation for the treatment of chronic pain. There's others on bleeding and coagulation management when implanting these devices, safety guidelines on reducing neurological injury, and last but not least, recommendations on spinal cord stimulation and peripheral nerve stimulation for chronic pain and ischemic diseases. And I'd recommend that you look at these articles, look at their recommendations, try to incorporate them into your practices so that you are providing the best care possible for your patients. And that is it. Thank you.
Hi, this is Dr. Stephen Falowski. I'm a functional neurosurgeon who's going to be presenting on late-breaking data on closed-loop stimulation. This data has been recently published in the Lancet Neurology journal. These are my disclosures. Significant to this talk is that I have been a consultant as well as equity ownership in Saluda, the company responsible for this study. I've also contributed to the research and patients in these studies. So first, I'd like to give a little background on what is an ECAP and what leads to closed-loop stimulation. Essentially, what an ECAP is an evoked compound action potential. What this is a summation of multiple action potentials that the electrode is able to pick up after it sends stimulation to the spinal cord. As you can see here, the morphology of a normal action potential. But keep in mind, this is the sum of multiple action potentials, and it's all judged based on where you have the stimulation coming from the electrode in comparison to the reference or recording electrode for the ECAP. Essentially, an ECAP provides insight into a measure of how many fibers and what fibers are being activated in the spinal cord. Now, specifically to closed loop stimulation, it's the ability to use an ECAP, or the summation of those action potentials, to give a measurement that will control each further stimulation paradigm or current. So what you can see here is the system generates a stimulus that is pre-programmed, and you capture the ECAP, or the evoked compound action potential. What you do is you record this now on each pulse, and you compare it to what would be considered your target ECAP, or the ideal ECAP that you're looking for. You program this ideal ECAP based on pain relief as well as its morphology, with the assumption that it generates or can generate what is the best pain relief. And now by the system constantly stimulating and recording, it's comparing each ECAP that it records to the target ECAP, or the one that you pre-programmed. And what the system will do is in real time constantly change the current that is going to the spinal cord in order to always generate the same ECAP. So essentially, this closed loop stimulation will change the output multiple times throughout the day. In fact, it will change it over 3 million times throughout the day. As you can imagine, throughout the day, you not only walk, sit, lie down, but you can also cough and sneeze throughout the day. For every millimeter that your electrode changes in the epidural space, you can lose or gain up to as much as 15% of the stimulation. That's why, therefore, it is more important to control the current to generate the same ECAP each time. Now, this is the premise behind closed loop stimulation. Now, there's been a significant amount of data in reference to closed loop stimulation dating back to 2014. There was an original panorama study performed in the United States, which was a randomized double-blind crossover study. This was done on patients during a trial where, after they had undergone a successful trial with any company, they were then hooked up to closed loop stimulation and further followed. This was done in 22 patients, and 86% of those patients preferred closed loop in this double-blind feasibility study. Now, this was followed up by a multi-center study performed in Australia. This was performed over a 4-year period from 2015 to 2019, known as the Avalon study. These patients were followed up to 24 months, showing a nearly 90% responder rate, followed out to 2 years. Now, in the United States, we have performed the Evoke study, which we're going to dive into more detail on the study. This is what has been published in Lancet Neurology. This is a randomized control, the first ever of its kind double-blind study, where 134 patients are enrolled. Right now, we have the data following out the patients to 12 months, but we will continue to follow up the patients, as you can see, till 2021, to also have 24-month data. 13 centers were included across the United States for this. This is a breakdown of the study. So 134 patients were randomized. It was double-blinded, meaning patients as well as physicians were not aware of what stimulation paradigm the patients were getting. They were either randomized to closed loop, which was the investigational arm, or the open loop or controlled arm. Now, the main point to take home from the way that these patients were randomized is in both the open loop and closed loop, they both were actually programmed utilizing the ECAP or generating an ECAP, and they were programmed to try to generate the best ECAP. The difference between the two study groups is that in the closed loop portion of ECAPs was turned on so that it can automatically adjust to keep generating that ECAP, as opposed to in the open loop, even though they were programmed to have the most ideal ECAP, they would not adjust in real time for positionality changes. These patients were then followed out to look at a primary endpoint of 3 months as well as 12 months. One of the important features of this is back pain and leg pain were not divided out. In fact, actually it was looked at as overall back and leg pain reduction, meaning that you would have to have a reduction in both to be considered a responder. Also, the patient population had chronic pain for greater than 11 years in this study, obviously demonstrating a very difficult patient population. From the beginning, the study was designed to reduce or eliminate bias. And what you can see here is some of the baseline characteristics of the two groups. And there was no statistically significant difference in the baseline characteristics. This included also the device usage of the patients, as well as the programming of the patients. Keep in mind that the patients were programmed to generate the most ideal ECAP, but then only the investigational arm had the closed loop activated. The procedure, including procedure time, were all done exactly the same, also blinded during the procedure of what the patient was going to get. This blinding was maintained throughout the entire study and continues on as they followed the patients. As I said, the only difference was that in the closed loop arm, they were able to have that feedback mechanism to adjust to always have the ideal ECAP. Now what you can see here is the primary endpoint at 12 months. Now this is in the intention to treat analysis. This is every patient undergoing a trial in the study. And what you can see is that 83% of the patients in the closed loop arm were considered responders at 12 months for overall back and leg pain reduction. What's also important is that the patients had to demonstrate no increase in the pain medications or a reduction in the pain medications. They would not be considered a responder if they had an increase in pain medications. What's also interesting is when you look at the open loop arm, this is some of the best numbers we've seen for traditional spinal cord stimulation, in which they had 60% responder rates. This is likely secondary to the fact that they were initially programmed to generate the ideal ECAP, which generated even better results. However, it did not generate the superiority that we see with the closed loop arm of 83%, because these were now adjusting in real time. So even though looking at an ECAP and measuring an ECAP can lead to better outcomes, it would still not be as significant as what you can gain in a closed loop system constantly adjusting to generate the ideal ECAP. They also looked at not only VAS pain scores, but quality of life measures. As we know, this is a big move in the space of neuromodulation, is to look at past VAS pain scores and look into quality of life measures, functional outcomes. 55% of the patients in the closed loop arm either reduced or eliminated their opioids, which is quite significant. The patients in the closed loop arm also gained additional sleep per day of 1.3 hours. That is quite significant when you consider that the normal sleep cycle can be anywhere from 5 to 8 hours in a night, and to gain an additional 1.3 hours of sleep per day is obviously very significant. We also looked at ODI to look at disability index for this patient, and what you can see is 51% of the patients had a reduction from baseline in that score, and 8 out of the 10 patients in the closed loop arm ended up reporting minimal or only moderate disability, obviously showing quite a difference in functional outcomes and quality of life measures. Now, something that we've been looking at over the last couple of years is not just responder rates of greater than 50% pain relief, but looking at high responder rates. So those patients who are obtaining greater than 80% pain relief. And what you can see here is that 56% of the patients in the intention to treat analysis, so all those patients undergoing a trial, were able to become high responders or greater than 80% pain relief at 12 months. This was in comparison to only 37% in the open loop or control arm with traditional spinal cord stimulation. Quite a significant difference. What's interesting though is that when you compare the results in the EVOKE study, the US study, as compared to the Australian study, they actually mirror each other for long-term responders. So now when you look at this, think about not just the intention to treat analysis, but also the modified intention to treat analysis. And what you see here is that there is an 89 to 90% overall pain responder rate at 12 months so far in the US study, and out to 24 months in the Australian or Avalon study. So I think in conclusion, looking at this data for the EVOKE study, first off, it's a double-blinded randomized control trial. The study design was of such high quality that it was able to be published in Lancet Neurology. This is a first of its kind for our space in neuromodulation. The primary endpoint was not just a single factor of back pain or leg pain. It was an overall pain of back and leg pain, demonstrating that you have to have response in both. Sustainable long-term outcomes in both the EVOKE US study as well as the Avalon Australia study. High responder rates of significance, 56% high responder rates in the closed loop or investigational arm, which was quite superior to the open loop, as we saw, of approximately 30%. This obviously leads to a higher remission rate. In addition, those high responders who were generating greater than 80% pain relief also demonstrated some of the most significant improvements in quality of life measures, sleep index, ODI, and those were correlative between the two. So as you can see, there's a significant difference in functional improvements that can come with the closed loop system. And I think for the long term, we're going to see there's a lot of data we can obtain from monitoring this long-term cord activation and monitoring these responses with ECAPs. To continue along with the data that we've been gathering on closed loop or ECAP systems, we've actually started to also combine this with neuromonitoring. As we know, we can use neuromonitoring and spinal cord stimulation to safely place leads as well as judge lead position in those patients who are asleep. However, there are some difficulties with neuromonitoring in the sense that you do need technicians in the room. You do have to hook up electrodes. So we sought to see if we can actually combine these two, and by utilizing stimulation and then recording of ECAPs, would it help us to determine the location and proper positioning of the electrode? So what we have here now is a multi-center trial with 2 centers that were utilizing neuromonitoring to place these leads and then measuring the ECAPs. And we took the patients from these 2 centers that were part of the EVOKE study and looked at them and see what kind of details we can find that the ECAPs can help us in judging lead position. So what we also know is that with the ECAP, if you follow the ECAP through, there is what's called a late response. It's that second blip you see there. Up until recently, until this data that we were obtaining, no one truly knew what that late response was. However, what we were able to do is correlate that late response with the EMG recording that we have on neuromonitoring. That EMG recording on neuromonitoring tells us the position of the electrode and whether we're left, right, and what kind of coverage we're getting and if we're covering a painful area. So we sought then to correlate that EMG signal with the late response. And what we saw was that there was always a 1-to-1 ratio. The late response correlated with that EMG signal. So then the question was, if we put the two together, ECAP, which is considered a signal or an action potential on the center of the spinal cord, with the late response, which is considered an EMG response coming out the nerve roots, if we can put those two together, could we determine how far medial or lateral we were? And we did. And what we could figure out is that ratio had to be greater than 1.5. So as you increase the current here, you see we're generating an ECAP. You continue increasing current, there's more ECAP. And then eventually you're going to get a late response. This tells you that you're very close to midline. The opposite would be if your ratio is less than 1, you would increase current and you would first get a late response telling you you're lateral before you would generate an ECAP. So what we did is we did this over numerous patients on the multi-center of the patients in the EVOKE study. And what we can see here is just a prime example of one of those patients where it's the top of the lead with the stylet in. The top of the lead was quite lateral, and that ratio dropped to 1.35 and actually created nerve root stimulation. While what you can see is even on the same lead, on the bottom of the lead where it's midline, that ratio can go to greater than 2 or greater than 1.5, which tells us we're on the midline. So I think in conclusion, we're still in the infancy of this, but what we're starting to see with this great data is that ECAPs now correlate with EMG signals and can potentially be used to offset technicians and needles being hooked up for neuromonitoring. In addition, we can look at different morphologies and waveforms to look at how they generate ECAPs. Can we objectively place these leads and see what patients are going to respond to the best? This is going to lead to objective lead placement and objective use of stimulators in the future. Thank you.
Welcome. I'm Dr. Jason Pope, Chairman of PSPS, and I want to welcome you to this session, which is the panel discussion. Obviously, we're in COVID times and we're wearing masks, social distancing appropriately, and we're going to talk about problem-based learning discussions surrounding dorsal column stimulation with patients diagnosed with PTSD. We have an esteemed panel today, and I'll turn it over to them so they can introduce themselves. Prasad.
My name is Ravi Prasad. I'm a pain psychologist at UC Davis School of Medicine in the Department of Pain Medicine.
My name is Cass Amir-Delphin. I'm the Director of Medical Research at RPM Medical Group, and I've been doing spinal cord stimulation for 20 years.
My name is Eric Lee, current president of PSPS and a pain practitioner with offices in California and Hawaii.
So we've assembled a really key folks describing spinal cord stimulation. Clearly, they've had, I think, a lot of experience in this world. I'm going to turn it over to Dr. Prasad to talk to us a little bit about some of the comorbidity management associated with PTSD, neuromodulation, and efficacy and longevity of therapy. So, Prasad?
So, with implantable therapy, such as spinal cord stimulators or with intrathecal pumps, we know that psychological variables play a significant role in determining outcomes, specifically negative outcomes. They have a stronger predictive value than pretreatment physical findings or pain intensity. Approximately 92% of negative outcomes can be attributed to psychological variables. There was a study that was done, I believe, last year where they looked at failed spinal cord stimulation in devices that have been explanted, and they found that in the patients that had the devices taken out, approximately 12% of these people had PTSD as a concurrent diagnosis. So it's important to make sure that we're paying attention to the role of psychological variables because they can impact outcome. Even if you have a technically perfect procedure, we know that the success that a patient experiences in terms of their functionality may be grounded in other factors outside of the device itself.
And we've done a lot of work with explant and spinal cord stimulation, and we saw something very similar, that about 75% of people that did not do well with neural stimulation long term was related to the lack of pain care, or lack of efficacy associated with the therapy. And there was a high proportion of folks that had psychiatric comorbidity. And we know this because we request a psychological screen prior to implant. So Kaz, tell me a little bit about that process for you. And have you noticed, or have you been asking your psychologist to specifically dive into certain diagnoses, or are we relying on them to help dissect who may be an appropriate candidate from a psychiatric perspective?
Sure. So as you know, our practice is actually quite large. We have 20 offices up and down the state of California. In our headquarters where I practice, we have 5 full-time psychologists. And these psychologists have already been trained into evaluating neuromodulation candidates in a lot of detail. Over the past few years, we've actually infused more education on PTSD alone because of the fact that we're seeing a lot of more of those types of patients in our practice. I don't think that PTSD needs to be separated from all the other psychological disorders, but there's definitely some additional training that's necessary for these psychologists to be able to discern who would be a better candidate and who would be a worse candidate for neuromodulation when they have PTSD.
We talk about the affective component of pain and the intensity scores on a linear scale, and we talk about measures to try to capture people more multidimensionally. Eric, in your practice, how are you evaluating folks for the candidacy for implant for those patients that have psychiatric comorbidity? And as a follow-up question, have you done anything to treat or manage that disease process prior to implementation?
I think you bring up a critical part of this. So, my general philosophy for all my patients is, pain is going to be part of life. Not everything I do is a miracle cure for pain. My goal for the interventions I do when I treat my patients with pain is to reduce their pain and improve their function. And a lot of times, as a physiatrist, it's easy to look at the physical functional components. So we do a wide variety of testing beforehand to check things, as well as like Beck's inventory and Pittsburgh sleep scores to check on those patients. But psychologically, it is challenging to see where they're at and how they're functioning. So what I encourage is, we do this psychological screening. And a lot of times in our community, I think people just, might overlook it. I encourage all members and all physicians to establish a relationship. Not all of us are privileged to have full-time clinical psychologists in our practice like Kaz is, or our PhD, brilliant clinical neuropsychologists like Dr. Prasad. So have relationships, talk to your psychologists. So when you get those reports back, you really understand what that screening process shows you and what the results are. And then set up a treatment plan for those patients to look at their wide variety of conditions. Obviously, we're talking about PTSD specifically, but there's a large component of psychological challenges that patients face, especially patients with chronic pain. So after we do the trial, we assess them. We have a plan in place where they're working with a pain psychologist. I'm fortunate to have several in my areas that I work with closely, and we send those patients to continue and monitor their progress through the trial and also after the trial to ensure long-term success. I mean, we talk a little bit about the science behind it, and you have brilliant panelists today with Dr. Chakravarthy, talking about the different mechanisms of action, and we often talk about the neuropeptides. And there's some science out there that shows a strong correlation between things like neuropeptide Y and the hippocampus and the TA synapses in the brain that are affected by stimulation, right? So it's not unheard of to think that there's an association with the spinal cord stimulation we're using, which affects neuropeptides in that pathway to have some effect there. We talk a lot about medial and lateral pathways in the thalamus. There's areas in the hippocampus that even if we stimulate downstream in a peripheral nerve or a dorsal root ganglion or a dorsal column, we can have significant ramifications on that long-term effect, which might give us some long-term psychological improvement as well in these patients.
And let's not forget, I think as healthcare providers, we're the primary point of contact for a lot of these patients. So a lot of this psychological support comes from us on a long-term basis. After the patients have been implanted, I continue my relationship with them, and I encourage all the nurse practitioners who work with me to continue to do the same, because there's a lot of variation to chronic pain. We have ups and downs for every single patient all the time.
Yeah, I've noticed that as well, that we see patients oftentimes at a higher clip than their primary care doctors do. So I think it is incumbent upon us that it's not chronic pain cure, it's chronic pain management, and oftentimes that's associated with psychiatric comorbidity management also. And we do have the privilege of having Dr. Prasad here, and he's done, I think, a tremendous job building programs that are supportive surrounding the psychiatric comorbidity care associated with neurostimulation. And we like to have digestible points that we can take home to our practices to improve healthcare in our communities. So what are some key features that we can implement in private practice or in academia that I think would ensure an opportunity for success for these patients that have psychiatric comorbidity, and certainly those for PTSD?
I would say one of the first things is to try not to frame the psych eval as a formality of just a process that patients have to go through, but looking at it as a true intervention that can help improve the outcomes of the patient. When we understand the whole picture, the whole context in which the patient is experiencing their pain, all the psychological, social factors that are going on, we're better equipped to try to help them. And oftentimes insurance companies are only going to give you 1 or 2 chances in a lifetime to see if the device is going to be effective. And if we know that these psychological variables can adversely impact the efficacy that patients receive, then it makes sense to try to address some of these things so that they've got the best likelihood of success with those devices. So explaining to patients from the get-go that this is an opportunity to look and see how we can optimize your care, ways that we can maximize the likelihood that this device will give you some benefit. And also, second piece is that the presence of psychological comorbidities doesn't preclude somebody from having a device. All it means is we just need to look and see if we need to do some other things to optimize their care first. There are a number of people that do have depression, that do have anxiety, that do have active PTSD. And it's not the presence or absence of these things. It's not a dichotomous thing, but it's more of how well managed are these symptoms, and is this person functional? And if not, then we make recommendations for what type of treatment they need to have. Simple case that we were talking about just earlier this morning, there's a patient that I saw where some of the rolling blackouts that we had in the northern part of the state had triggered some PTSD for this individual, and they were being seen for a spinal cord stimulator evaluation, and they were in the midst of active PTSD that was completely untreated. And so we made a treatment plan to try to get that addressed, and said that it's not that neuromodulation's off the table for you, it's just on hold until this is settled down. The patient went to treatment, came back in about several months later, still had PTSD symptoms, but they were much more stable, stable enough to the point where they were able to be moved up to being a candidate for trial.
Are there any red flags that we can look for as clinicians in our practice with PTSD patients?
I would say the key thing, just the untreated nature. So if a person has the symptoms, but they're not able to manage the affective distress, manage the flashbacks, the nightmares, things along those lines, then that's the big red flag. But just the presence of those by themselves, that's a yellow flag, and it warrants further exploration.
Excellent.
And so I do want to thank our panel. I think we're running out of time here, but I think in this time of COVID and being socially distanced and isolated, I think we've made good points that we don't want to overlook the importance of the psychiatric evaluation in managing patients with neuromodulation and then partnering with folks, I think, to really give our patients the best chance for success. So with that, we'll conclude the session, and we appreciate your attention. Thank you.